Okay, should I start? Okay. My name's Steve Berman, and I'm the director of the Center for Global Health, and a good friend of John's, and we're so pleased that he's here and participating in our global health course and being able to give this talk on polio. I'll tell you a little bit about John. He actually is a family doc like his dad, and he still takes his certifying exams, so he's still able to practice. He went to the Peace Corps and got really turned on to global health, like a lot of people have. And then he was with the CDC. And when he was with the CDC, he was assigned to India, and he had a major role in the Indian experience with polio eradication. He then actually was the deputy director of PAHO and was very involved with a lot of important vaccine initiatives at PAHO. And then he went and was the medical director at the Sabin Vaccine Institute. And he's now recently taken a position as an adjunct professor and the director of our immunizations and vaccine program at the Center for Global Health. And that's a half-time position, and the other half-time he's with the School of Public Health and Global Health at GW. So I don't know of anyone who's been more involved in polio eradication efforts and policy efforts with polio. So we're all looking forward to hearing where we're at on polio eradication. Thanks, John.
Can you hear me? Thank you, Steve. I must say it's a privilege and an honor, pleasure to be here with you. I, coming early, have had a chance to meet many of you in the audience, particularly a team of Rotarians who are here. I, in preparing this talk, wanted to dedicate it to my guru and dear friend and colleague, Dr. Ciro de Quadros, who was the grandfather of the strategies to eradicate polio, I believe, in the Americas. But I should also dedicate it to many of you in this room who have dedicated much of your professional life to the eradication of this disease. I had early on a personal interest because my former wife had polio as a child, and my dad was a family doctor, and many of his patients in a small rural town of King City, Salinas Valley, had the consequences of polio. So I got exposed very early on, and have always been very passionate about this effort. And Cyril fed that passion. He was a true leader who exhibited courage, values of equity that polio eradication can achieve in reaching every village, every child, and the vision, seeing how polio can affect public health infrastructure and develop capacity, and most importantly, in my mind, a whole new generation of future public health leaders. So thank you, Steve, and also acknowledge Dr. Edwin Asturias, who's on the faculty here, in his former efforts in Guatemala, because it all begins at the national, local level, and Edwin had a key role in that effort. So Cyril, this is 2 months before he died. He had fought and won the battle with distal esophageal cancer. I'll never forget when he was diagnosed, he whispered in my ear that this is a battle I cannot win. But I must say that up until 4 or 5 days before his death of pancreatic cancer, he was working, and he was totally passionate about saving more lives more quickly. So the Pan American Health Organization at this time was able to recognize his life contribution. My presentation is divided into 2 parts. One is I'll give you a flavor of the history and the background of what happened up until the year 2000. And then the second part is what has happened in terms of progress, but also the challenges that remain. And I've asked this question: is it the end of the beginning or the beginning of the end? I have a perspective, but I'm reassured that with the commitment of Rotary and the commitment of other partners, WHO, UNICEF, and all the NGOs and all the governments and all those health workers and vaccinators in the field, that despite the remaining challenges, it will get done. But I want to leave a message that there is still a lot to be done. So I assume that many of you know the history of, and the background of polio in the United States, the emotional attachment that some of us have. I can tell by the age distribution that many of you know of folks that in your family, amongst your friends, a colleague here sitting has had polio. Generally, when I ask this question in other audiences, there's always some proportion of the audience that responds. So that emotional attachment, you know about the disease. So I'm going to skip through slides, but let me ask the audience: are you familiar with the epidemiology and transmission of this disease? Do I see anybody that is not? Raise your hand. Because I really want to spend most of my time developing the evidence for what needs to be done. And that's the second half of the talk. So I'll go relatively quickly through this first series of 10 or 15 slides that, you know this is a virus that cripples. It dates back to Egyptian times, but it wasn't until 1789 that it was first described by Michael Underwood, and we've had outbreaks first documented in 1843. Our last 3 outbreaks in the 70s was when, as a country, we were able to interrupt transmission. But in 1952, there were 21,000 cases of paralytic poliomyelitis. One of those cases was my former wife, as I mentioned. As a result of the efforts and best practices, particularly in countries of the Americas, there was a global resolution in 1988 to eradicate this disease. So that was a 12-year time span. It was meant to be time-bound, limited, get the job done, and move on. This is a virus that's RNA. It has 3 types, so it's really 3 different subtypes. They act differently. And if you've been infected and develop immunity to one, that doesn't necessarily mean that you have immunity to all of them. That's what we mean by minimal heterotypic immunity. And it's very heat unstable. Heat will kill it. And that's why the cold chain for the live virus vaccine is so vitally important in protecting its potency. It is spread by oral fecal route. It replicates initially in the pharynx and GI tract, then spreads into the local lymphatics of the GI tract to ultimately the central nervous system, where it can affect the nerve fibers and cause destruction of the anterior horn cells. Most of the infections are asymptomatic. This is what makes this disease difficult to eradicate, because you don't know the person's infected. And in fact, for every case of paralysis, there may be up to 200 or 1,000, depending on those 3 types causing the paralysis, that may be inapparently affected, may be asymptomatic. So the variance there, one case of paralysis for every 200 or up to 1,000. So you may identify one child as having paralysis due to polio, but that means that community is infected, or that county or district or municipio, or multiple municipios. And that's why the campaign strategy with the oral polio vaccine is so vitally important. There are other presentations and much fewer percentage affecting people that are infected. So as I mentioned, probably on average, less than 1% of the infections develop paralysis, but there is that range I mentioned. From a public health perspective, it's a syndrome known as acute flaccid paralysis. I'm sure many of you have heard this term, but that's the approach in public health that we take by identifying that syndrome, investigating all those cases, identifying which have been infected by the poliovirus is the path to eradication, because it maintains the sensitivity of the approach. You're going to capture all viruses, at least all communities, taking in the notion of inapparent infection, and you'll be able to target interventions. So a sensitive case definition of acute flaccid paralysis, very sensitive, and then specificity kicks in with an excellent laboratory support. So we really need that public health laboratory infrastructure that can validate that the cause of the paralysis is due to wild poliovirus infection. And the differential diagnosis is included on this slide. There are other viruses that cause paralysis. There are other syndromes like Guillain-Barré syndrome, and so on. And that makes it challenging. The epidemiology is such that, in which the first point making it an eradicable disease, that it's only transmitted among humans, that the transmission is oral fecal, the communicability you see here 7 to 10 days before onset of paralysis, and the patient can excrete up to 6 weeks. To summarize what makes polio eradication eradicable, what makes it possible, I mentioned the absence of an animal reservoir. There are effective vaccines and strategies largely proven in Latin America and the Caribbean through the leadership of Dr. de Quadros and partners such as Rotary and others. Chronic carrier state is largely, we'll see that it is a small risk, but it's largely not a risk, and there's a short environmental half-life, and there is a need to have political commitment and adequate financing up front, because I'll show you examples when the financing becomes limited. Generally, the knee-jerk reaction is to restrict the necessary strategies. The virus is smart. It will come back. So maintaining scientific, technical rigor, that was something Cyril was very courageous. He would stand up on the table and say, we cannot go forward unless we have the necessary resources. This is the way it's done. And not compromise. When we compromise, you'll see over and over again how this virus can make life difficult. I mentioned the inapparent infections. I mentioned the differential diagnosis, the surveillance being factors that make it challenging. We'll also talk about the circulating vaccine-derived viruses. The initiative is the eradication of all polioviruses. There's wild virus. There are viruses related to the Sabin live vaccine. And it must be the eradication of all those viruses, because if we only eradicate wild virus, there'll still be cases of polio-related paralysis in the world. We have not done our job. So we must maintain that vision. And I'll get back to that. So I mentioned the 2 excellent vaccines, the scientists involved with their development, shown here, Jonas Salk and Albert Sabin. The oral polio vaccine is highly effective and provides 95% immunity after 3 doses in most situations. I'll cite the exceptions where efficacy drops, particularly in very, very poor, crowded, unsanitary conditions. And the immunity is probably lifelong. But the fact that it can be given by a volunteer, it can be given by the oral route, and it provides gut protection more than the injected vaccine, it logically became the vaccine of choice to stop transmission. The IPV, or the killed vaccine, emerges as an important intervention when we achieve the ultimate target. We've stopped transmission, but we still want to protect children in case there was an accident in a lab, a leak, or we missed something, or there was bioterrorism, all these other risks that we would want to mitigate by continuing vaccination for some period of time after the last polio case. And the nice thing about the inactivated polio vaccine, it doesn't have the adverse consequences that the live virus has. The live virus vaccine can actually mutate to that circulating vaccine-derived form that I mentioned. So think of circulating vaccine-derived viruses as having originated from the polio live vaccine, the Sabin vaccine. They have mutated, and unfortunately, in rare situations, they've acquired 2 important actions: the ability to transmit from child to child and the ability to cause severe disease. So this circulating vaccine-derived virus can cause outbreaks, can cause paralysis, can spread. So it's actually reverted back more or less to the wild virus form. That's the way we should be thinking about it, and that should be our target. The other consequence of the oral polio vaccine is that in rare cases it can cause what is called vaccine-associated paralytic poliomyelitis. This is not a virus that transmits or causes outbreaks. It's an episodic event based on, I believe, 1 or 2 mutations that can cause the paralysis in the child of receiving the vaccine, or the mother who may be susceptible, who's exposed to the child receiving the vaccine. It does not cause outbreaks. It's that one event. And that's what we call VAP. You'll hear this term. So 2 major risks are VAP, very rare, and I'll show you data of the study we did to quantify that. And then the circulating vaccine-derived poliovirus adverse event that can cause actual outbreaks, and that I and others are concerned about how we're addressing and being sure that we're not, we're considering that in the same vein as we would wild virus. So I've covered these slides, and I've covered the differences. Again, to repeat, to eradicate, stop transmission, OPV is the vaccine of choice because of its intestinal immunity as well as the humoral. It's very cheap. It can be given orally by volunteers, by Rotarians. And herd immunity is substantial. Now, when talking about any eradication program, these are key guiding principles, not just for polio. It could be for measles, rubella. It could be for any disease you're thinking about if you want to get to 0 cases. You need to rapidly as possible immunize the susceptible population, coupled with excellent surveillance so you can monitor how well you're doing your job of vaccinating when you've reached the target and whether you've been able to maintain the gains from the efforts, sustaining the gains. I'll come back to this again, because oftentimes we do the job in certain countries, we don't sustain that success. We may stop an intervention like a national immunization day. We may do less in terms of reaching these children with routine. Our focus then shifts elsewhere, and these children remain at risk. sustaining the gains. And that's what I hope we stop repeating, as you'll see in the story I'm about to tell. Cuba was fundamental in the way Cyril took the data, the evidence to convince ministers, because it showed that with one campaign it could stop transmission. Now, people would say Cuba's an island. It's different. You could stop transmission with one campaign. Okay, well, Costa Rica was a country that did it, and please remember the lessons from this slide, because you see the routine program is shown on the line here in dark, in black, the cases in blue, and then the campaigns, the national immunization days. And you see there was a marked reduction in disease burden, but they stopped the campaign, or they lengthened the interval. But in this case, they stopped. Susceptibles build up, and you get an outbreak. We'll see this in other examples. So, sustain the gains. Again, the key message that we've known about for a long time. The other important experience was the program coming out of Brazil, where, the question is, okay, Costa Rica, Chile, Cuba, they can do it, but what about a big country, a challenging country like Brazil? And clearly these data show that with adding the campaign to the routine immunization program, in the case of Brazil, the National Immunization Day done once a year, basically 2 rounds. You give all children less than 5 years of age in the country, regardless of their previous vaccination status, and then a second dose a month later. You can see the effect that represented by the arrows, and then subsequent interruption of transmission. So these were data, after working with Cyril, that I could take, convince Dr. Harshvardhan in the district of New Delhi, which then helped generate support combined with the efforts of Rotarians in India at that time, but convince key policymakers that India can do it, or that Bangladesh, Nepal, and so on. Key data and the use of strengthening commitment and political will. So to summarize, some of the basic strategies that are specific for polio, I gave you the overall guiding principles for an eradication program, but I've mentioned the national immunization days, the 2 rounds, once a year, targeting all children in a country less than 5. But you really need a strong immunization program. You need that routine coverage up high as a basis of providing population immunity. And we've made, it's either been a mistake by not putting enough emphasis on it, or that conditions are so challenging in the case of a war example that we're being confronted with now that it makes it very difficult. Factors out of control of the program. The surveillance of acute flaccid paralysis with the laboratory support is absolutely fundamental. And then finally, after achieving high coverage, achieving good quality national immunization days, in some countries there were still pockets of transmission. So we went in to do what we called mopping up. These were house-to-house vaccination campaigns in the area where transmission appeared to be focused. And a good example is the Atlantic coast of Colombia. If you can envision that strip on the northern coast of Colombia, there were 3 cities in particular, urban centers, that were reservoirs for polio transmission all along the coast there. Cartagena, Santa Marta, and Barranquilla. So a mopping up campaign of that whole coast, targeting all children less than 5, going house to house, stopped transmission in Colombia, and it did so some 4 or 5 months before Peru, because in 1991, Peru ended up having the last case on August 23rd, 1991. So it goes without saying, political will coupled with the necessary financial resources. the strategic plan, the roadmap, at the local level, at the regional level, at the national level is critical. I've highlighted elements of that strategic plan. I think you all know about strategic plans and how critical they are in directing the focus towards a target. It provides the vision, it operationalizes the scientific components that we've discussed, it prioritizes, it incorporates lessons learned, it produces results, it's accountable, you've got to report back to be sure that you're on track with the plan. It promotes partnerships. It has a role for all partners, including UNICEF, including partners like AID, Rotarians. And in those campaigns that I mentioned, Rotarians not only contributed financial resources, they were out vaccinating. I'll show you a woman Rotarian in India in a subsequent picture. So the partners like Rotary, and I think in particular CDC would donate financial resources, but they were also a technical partner. And I think that model of having a financial plus a technical partner brings in the buy-in. I'll never forget in India, Raja Sabu asking me, what else can we be doing? Can we help surveillance? We hear you talk about the importance of surveillance. We're out vaccinating. What else can we do about surveillance? And we brainstorm strategies where the Rotarians could actually, at the community level, promote surveillance. Expect the unexpected, you'll see. And as Bill Fahey, this is a quote from Bill Fahey, a former director of CDC, always said that disease eradication fights inequities and creates social justice. So principles. Some of the general lessons I wanted to highlight coming out of PAHO as we come closer to the 2000 first phase of this talk, the importance of surveillance, again, the coordination with the lab network, testing new strategies, testing new technologies. I'll never forget that at that time there was a transition from immunology to genetic sequencing and the PCR and the vision to get PCR labs operating in every country. Now it's just about every hospital has this technology. Back in those days, that was a major breakthrough for expanding capacity and infrastructure that would not only help polio, but subsequently the prevention and control of other diseases. A better understanding of the risk, as we'll see in the next slide, and this need to sustain the gains. We were able to look at our surveillance data and better define the risk of vaccine-associated paralytic poliomyelitis. The bottom line is that it was very comparable to what we were seeing in the United States and Europe. So it was reassuring that we could continue using this vaccine that the United States had used and Europe. And we also did work in environmental surveillance at that time. Environmental surveillance will help at this stage in the polio eradication program, but we felt back then that it was supportive and that we didn't want to put a lot of financial resources into environmental. We knew that or at least we had hoped and expected, turns out in hindsight we were right, that the focus should be AFP surveillance and laboratory. Let's put all the resources there. We weren't operating with a lot of financial resources. The program now per year costs globally $1 billion. We were well below that. So, but we did, and I think we helped set the stage that there could be a role in certain situations, and it indeed is being done. So here's Luis. He's the last case, lived in Peru. August 23rd was his date of onset. Amazing. And his mother is on the left there, and the National Immunization Program Director is on the right. So we learned a lot, particularly about capacity development, political commitment, technical and operational excellence. I've heard Tom Frieden, when he was director of the CDC, say this over and over again. When someone would ask, well, what'd you learn? political commitment, technical and operational excellence. A beautiful way to succinctly summarize what needs to be addressed, as well as partnerships, but that capacity development I mentioned. I did want to mention the Taylor Commission, because this was the courage of Cyril. Carl Taylor was a hugely recognized leader in primary care in developing countries at Johns Hopkins. And he was not an advocate of eradication. So what did Cyril do? He made him chair of the commission, and he called it the Taylor Commission, which assessed the impact of polio eradication in the Americas. And Carl did a marvelous job, and at the end of the day, he said, you know, this was a very beneficial program. So I wanted to share that with you. So using the experience, going to other parts of the world, using the lessons I mentioned. Here is the Indian vaccinator. She is a Rotarian, and this is one of the campaigns in India. I wanted to show you data on the value of this vaccine, looking at what happened in Orissa in 1998. I don't think I've ever worked with a more dynamic leader than the Minister of Health of Orissa at that time. We had done mopping up campaigns in Latin America, but the numbers in Colombia, 9 cases of wild poliovirus cases. When we did it in Guatemala, throughout Central America, including Guatemala, there were some 3 cases. So the numbers were very small. She was dealing with a large number of cases, and she decided to go house to house. That jump with a large number of cases, go house to house with this vaccine that the debate was occurring. And what she was able to demonstrate by reaching every house, reaching every child, in one of the 8 poorest states of India, with all the challenges of crowding, poverty, she was able to stop transmission. And my point is, the vaccine is good, but any vaccine, when you're missing 10% of the population, 10% of the children, nothing's going to work. You really need to achieve better success and have better quality campaigns. And she was quite a leader and able to do that, immunizing some 1.7 million children in those districts of her state of Orissa at that time. So the program in Southeast Asia had the benefit of being able to mobilize resources for India, Nepal, Bangladesh, Myanmar, Thailand, Indonesia, and in those countries we were able to stop, being government-led, to stop transmission and create high-quality surveillance. And at that time in 2000, remember, the first half of the story, that's the target, the year 2000. That was the WHA resolution in 1988. And India brought cases down to an all-time low at that time, 264 that year. And in other regions, not to mention the Western Pacific region and Europe, they were highly successful. I don't have time to show you the data or tell the story, but there was amazing optimism. Now, going forward, I want to share some of this progress, much of which is successful, but there have been setbacks and challenges. And the Rotarians, more than anybody, know it. And they have stuck in it. You've been there every step of the way, because you don't walk away despite the challenges. And that's what's needed. So in India, the strategies up until 2001 was a combination of the national immunization days and the addition of subnational immunization days in those 8 poorest states. And the strategy was called the 4+2. So 4 national plus 2 more rounds in those northern states, largely bordering the Ganges River, where most of the Indian population resides, most of the polio occurred. When that was downsized, in 2002, polio came back. So what happened in Costa Rica happened here. And it also led to India seeding other parts of the world. Certainly at that time, Nigeria was still overwhelmed with polio, and they were exporting viruses throughout Africa, but you can see the effect that India had on the rest of the world. So the question of vaccine keeps coming back. And these are good data. These data compare trivalent OPV dose with a monovalent dose for type 1 and in Egypt and in India, and you see that the type 1 monovalent provides better protection. The problem is to use that as a public health intervention, only going into the field with a monovalent vaccine, recognizing there are two other types of polio, namely type 3 lurking there, looking for susceptibles, then you're going to have this cyclic outbreak when the program went back and forth between the monovalents. So hopefully we will not do that again. But it set the program back enormously, because I can remember many of the partners were getting donor fatigue. They were wondering if we would be able to do the job. A little bit more about the risks. I told you about vaccine-associated paralytic poliomyelitis. Remember, that's a one-off. It's not spread causing outbreaks. It happens to that unfortunate child or mother. The risk we documented in the study I showed, as well as other studies. There is this eye vaccine-derived poliovirus that's also been identified in people who have gammaglobulinemia, hypogammaglobulinemia. At the time of this slide, this is probably 5 years old, so the numbers have probably boosted up, probably not 19, but probably closer to 30, if not more than 30 worldwide. So it's a rare event, and the point is these individuals can excrete the virus for months, even years. So if you're excreting the virus, it provides an opportunity for the virus to mutate. And I need to say that because that is a risk. If it mutates, we don't want it to mutate to circulating vaccine-derived polioviruses. And which leads to the next point. We've been seeing those outbreaks due to this vaccine-derived poliovirus, about one per year. Usually they're limited with 20 or so cases of paralysis, with the exception of this year and last year in Syria, where we now have 47 paralytic cases, I believe, in a war-torn country. And we're seeing, as I'll show in data, other countries that are currently challenged with this virus. We saw it in Hispaniola in 2000. It emerged in Haiti and spread through the Dominican Republic. Just to say that it's a risk anywhere in the world where coverage of the oral polio vaccine drops. So you get a lot of susceptibles, so that if a virus mutates, it can find its way to spread and cause an outbreak. So the treatment is a campaign. Go in, vaccinate, get the coverage back up. This virus will be interrupted. So the circulating vaccine-derived virus should be considered as a wild. The intervention is the same, and if done well, you will be successful. The IVDP that I mentioned, those rare excretors that have hypogammaglobulinemia, in most developing countries, they don't live very long, unfortunately. They'll die of infectious diseases. But this shows an age distribution of those data that I showed earlier for your interest. So things went along, and then in 2014, there was another instance of significant global spread of the virus. And unfortunately, certain areas of the world, namely the Horn of Africa, got reinfected. Now those, I'm sure that you've been following the story, vaccinators were killed. They put their lives at stake in many of these war-torn communities. Bob Keegan, when he was alive at CDC, told a story of where he was held hostage and he worried that he was going to be killed. And it actually led to him having a very traumatic experience that took some recovery. And then afterwards, you may recall that Bob rode his bicycle across the United States to try to mobilize resources for polio eradication after his retirement from CDC. So it came back. And I'm saying this because, remember, sustain the gains. Now, this is a slide showing data from 2000 to 2014. The cases caused by circulating vaccine-derived polioviruses. I don't want you to, what I want you to focus on is Nigeria, showing that viruses caused by this variant of poliovirus were being transmitted for many, many years. And my point is, that is a risk. That happened. That's a fact that going forward we need to prevent. So the current situation in Pakistan, there's been substantial progress if we only talk about wild viruses. The numbers are clearly down, as with Afghanistan. But again, concerned about the results of environmental samples that are showing wild or that are showing circulating vaccine-derived polioviruses. The job isn't done. So when we communicate this message, I believe we need to tell an honest, complete story and be very transparent about the risk. This slide is it needs to be updated because there are now 5 cases. Most recently, in August was the last date of paralysis. It takes about a month or so for the labs to turn around the results. So it's a very recent case. And we're seeing in Pakistan, as I'll show on this slide, 4 distinct areas of reservoirs. So it's not just one reservoir. So that is a concern, that it's happening in 3, 4 different geographic areas of Pakistan. Similarly with Afghanistan, there have been recent cases isolated. We were all hoping that we would have stopped transmission last year, and this is the point I want to make. We haven't, and so we now need to mobilize sufficient resources that will cover the resetting of the clock. And a concern that's emerging is we've done an amazing job with Rotary and CDC, a recent meeting in Atlanta, to mobilize more resources. But it didn't take into account that we would still have transmission this year. And when you're operating on a $1 billion budget per year, we need to be sure we will not compromise technical strategies or fail to sustain the gains. In Africa, we have 4 viruses that popped up in Nigeria after having a period of no wild viruses. And the problem was Borno, where there was the civil war going on, and there was no access. But we wanted to celebrate that there had been no wild virus isolation. And it turns out then in August, that was July and August of last year, cases were identified, a total of 4. And that whole Lake Chad region is at risk. There have been some very aggressive response to this. There have been 5 synchronized outbreak rounds in 2016 and 2 so far this year. The last case of this finding in that state has data onset of 21 August. Now, I hesitate to say something like it's more than 1 year. I think that's what the results show, but let's be honest and be concerned. We don't know in many parts of Borno what's taking place, as indicated by these red areas we have no access. And the environmental surveillance, this is a slide from showing 2016. If I was to show a slide this year, it probably would not be that different, but it highlights the challenge that we can show where the wild virus is being isolated by case identification, but the environmental surveillance is also showing that there is, widespread isolation both in Nigeria and in parts of Pakistan and Afghanistan. And how we manage those results, how we respond to them. Yes, many of them are due to migration of people. They may stop at a place, leave the virus. The virus is picked up through the environmental surveillance. That person moves on. But it's an indicator of the challenges ahead of us. The next couple of slides are more positive, showing that it is remarkable that we haven't had type 3 cases recently, and that the diversity of the poliovirus continues to diminish, which is an excellent finding. The question is, have we eradicated type 3? We might have, but when places like Borno are happening, we can't say. So to summarize, the status of polio eradication in the United States, as I mentioned, the last outbreaks were in 1979. We had the last case in 1991 in the Western Hemisphere, and we were certified in 1994. CRO certified its region polio-free in 2015. That was a remarkable story, because many felt years and years ago, if India can do it, the rest of the world. But we didn't take into account the major obstacle of war and what war does to health, but how it prevents access to not only the intervention, but determining the presence or absence of disease. Type 2 was eradicated from India, it turns out, in October 1999. That was the last type 2 isolate that has ever been isolated. The type 3 I mentioned, we now have 4 of the 6 WHO regions certified polio-free. We should be very proud of that. This is remarkable progress. The entire African region has not had a wild virus case, but that makes since August 2014. So the recent cases in 2016 was a major setback. And we do have some progress in Nigeria and Afghanistan and Pakistan if we look at particularly just wild virus. But I wanted to inject that note of concern that there are other issues that we need to be remain diligent, not drop our guard, and specifically the challenge of circulating vaccine-derived polioviruses and the results of environmental specimen testing. To take a deeper dive into the summary of the remaining reservoirs of wild virus. So August 2016 is the last case in Nigeria. Pakistan has had, unfortunately, a recent wild poliovirus type 1 case as of 24 August. And we note that the results of the environmental surveillance shows more widespread isolation. The Afghanistan most recent case was in July of this year. We have 2 situations in other parts of the world, namely Democratic People's Republic of Congo, where they've had 9 cases of circulating vaccine-derived poliovirus type 2, with the latest in June of this year. And Syria has that ongoing outbreak that now has 47 cases, with the last case occurring in August. So I'll speak more to the path forward, but people are talking about the polio transmission, the need to ramp down resources. I'm hoping to inject a note of caution with that. There is some transition going on in polio priority countries, and it's important that countries take more ownership on the resources. The point being that the support, particularly coming from Rotary and other partners, will not be forever. There has to be some planning that takes place now. So it's that balance. The balance of the concerns that I've highlighted with the need to recognize the world is such that we can't afford to do this forever. I believe that it will be done, but it's recognizing the timing of these decisions so that we do not lose sight of protecting the gains. Going forward, I mentioned the program costs $1 billion a year. I show this slide. These numbers, this is a couple of weeks old, but the trend is still there. What I wanted to point out in this lower corner, if we look at 2017 compared to 2016, it's interesting the flip in the numbers. Yes, we're at an all-time low from 21 to 9, and but the circulating vaccine-derived viruses are going up, and it used to be a flip. So I want to be sure we don't lose sight of this problem, that we're not only focused on wild polio virus. So eradication is the eradication of all viruses. That means stopping OPV at some point in time, as I had alluded to earlier on in the talk. And there's a strategy, and it will be done in 3 phases with ultimate withdrawal. You may remember last year the switch from trivalent to bivalent, an amazing global effort done by countries. Incredible. If you think about being in that remote clinic in that refrigerator and being sure that all vials have been replaced, that the trivalent has been discarded in every clinic of every country. And having done that in that time-bound space of April, Global Immunization Week was a fundamental tactic to help with the success of that. So ultimately, removing all OPV and leading to IPV exclusively being used. But the problem here is that the supply is an issue. We don't have enough IPV. So again, an incredible challenge going forward. We're asking countries to do, I'm blocking on the term right now, but it's an intradermal dose-sparing approach. How many of you have given BCG subcutaneous intradermally? We have a couple. It's certainly very different from giving oral polio vaccine. It requires technique, it requires practice, and so some countries are being asked to deliver their IPV in a dose-sparing methodology that needs every nurse to know how to do it intradermally. It's not to say it cannot be done, but it can. But when the supply is low, then you're going to have other challenges coming in. There are countries that have already had disruptions. And then expect the unexpected. We don't know, given the world that we live in, when conflict will arise, when it will resolve. Hopefully it will resolve with the remaining reservoirs where vaccinators can get in sufficient time to vaccinate. And that was one last thing I wanted to say about Cyril, his courage. He negotiated the truce in El Salvador and in other countries, but particularly El Salvador, to get vaccinators in to eradicate polio, help the country eradicate polio in El Salvador. Días de tranquilidad is a term now being used for such interventions. And then, are there other Bornos? So trying to analyze access to geographic areas. Are we missing other Bornos? Here's an analysis that WHO did showing, well, there may be. So the transition, a final point I want to cover, is that is being led by Sir Liam Nelson as the chair of the Polio Transition Independent Monitoring Board. I have the honor of being a member of that board. And what we're trying to do is balance all these concerns. I mentioned it's incredibly complex, it's challenging, and a lot of education, a lot of insight will be needed, and a very strong country voice, country commitment, transitioning to country ownership, but still maintaining a funding base, a partner base that will see this as a legacy to our children. So the current presence of the polio program is highlighted here in this graph. We know that there are 70 countries with the support, but 95% of that support goes to the 16 prioritized countries you see color-coded here. These countries that are highlighted there have these problems. They're where 53% of the 20.8 million infants who did not receive measles vaccine. This is where 88% of the childhood deaths occur. So you begin to see what's at stake, what's on the line. If we ramp out rather than gradually, carefully, strategically ramp down, children's lives are at stake. And we miss the opportunity to eliminate measles, rubella, and congenital rubella syndrome, I believe. So just to end showing the responsibilities in those 16 countries of what polio officers do, funded by partners like Rotary, they do it well beyond polio, and the issues are listed here. So without their support, you can imagine what South Sudan would be left with. So it needs to be carefully planned and thought out. And I'll stop there. Thank you very much for your attention, and thank you for coming. Be glad to, in the time we have, address any questions. Madam, and then I'll come. Madam.
Could you talk about the polio supply? Because my understanding is there's an estimated 50% shortage until 2022, so how might that work?
So I showed the supply challenge and the shortage, and one strategy was what I described in terms of the dose-sparing approach. And another, I was personally involved with efforts. Some countries in Latin America in particular have a policy in place for 2 doses. And the data, largely done by a study that Adjoint participated in, maybe it clearly shows that 1 dose during this time would work, and 2 adds additional benefit, but during this critical time, 1 dose would be enough. So you have to get the country to change it and accept that policy in the interest of the world. And that in itself is a challenge. But countries are doing it, fortunately, in the effort. The Americas has been on the recipient end of the delay. We've been polio-free since 1991. So these things that are emerging, we send consultants out that have had the experience and have been participating in other ways when outbreaks arrive. But it's tremendously important that the job get done, so that, since 1991, how many years is that? It's a long time to be engaged and waiting for it to get done. So there was a question. Yes, sir.
Back in 1951, when I had bulbar polio, my wife had lumbar polio. Not this wife, my first wife. We didn't hear of types 1, 2, and 3. When did that come about?
Well, that, with the isolation of the viruses done by the Nobel laureate work of Andrus and his team, Fred Robbins was actually the chair of our regional certification commissions. I had the honor to work with him on those issues. They had determined that there were 3 types. I can't cite the article, but the vaccine had to have the 3 components. And Albert Sabin, having had the privilege to hear him speak in public about the sophistication and the analysis he did in laboratory animals and learning how the different viruses interacted and how their infectivity changed according to the organ system where they were in kidneys. It turns out that kidneys became the mechanism of cell culture or other tissue, neuro, or intestinal. So there was knowledge pretty early on in the vaccine development. Yes, sir.
From your map that shows regions with instability or conflict, the map that showed the regions that have the conflict, AFP surveillance has always been the backbone of detecting diseases. So I think as regions in Syria and the Sahel and Nigeria, I mean, what are strategies that you can think of besides military intervention or other strategies to help ensure surveillance and vaccination? I feel like it's always kind of an ongoing cycle of whatever's insecurity, it pops back up again. So what are your strategies or thoughts on that?
That's a great question. For those that didn't hear, the question has to do with what additional strategies in areas of insecurity or war or strife can be done to ensure that we're doing everything we can with surveillance. With the case of Borno, I know that children coming out are screened. There are stool samples taken for testing, even though they may be normal, just to see if they're asymptomatic carriers, because if they're positive, then that shows that their source from the village they came in, you could then say with relatively good confidence there's circulation there. And so you can keep, and if you can't get there now, at least you have it flagged as a priority area. There are other things that we actually did in the Americas. We used to get some 5 specimens of contacts of cases. So if a child lived in this house, we would go around the neighborhood until we could get stools from 5 different contacts, just to see. We were learning about circulation in these very impoverished circumstances. But that used to be a policy, contact investigations. Well, we're turning back to that in some of these difficult areas, investigating contacts, because the more we know about that virus, the genetic evolution, the sequencing, it all helps to do and help target the activity. So those are examples of a couple of things, and just using every intervention. There's the mapping and photographic visibility now. Villages in the past have been missed. Sometimes they pop up overnight. I remember in India, there'd be a slum that wasn't there on one day, and then you'd have a couple hundred people living in this field the next day. And having images of that, and then you can better track and target surveillance. I hope that answered your question. Sir?
Just a comment. I think one of the most important things in this question is returning to women, neighborhood teams led by the women of the neighborhood that has allowed better coverage.
Yeah, excellent point. Dr. Berman gave a nice talk yesterday, a group of students highlighting the importance of women's education and knowledge about the interventions, because they have a lot of control over the health of their children, obviously. And probably the starting point is educating the young woman, the female, the girl, at the earliest stage, and empowering her with the knowledge of prevention. Great question.
Great. I think because I know that some people have to go, but I think John can handle individual questions afterwards, because we're 5 minutes over. But I want to thank John. A great talk, and I know that people are really interested in this update to see where we are. and to answer the question that you phrased at the beginning of the talk. Thank you.
Thank you.